My name is Karsten Klabe. I'm working and living in Düsseldorf. We had a long ongoing discussion about should we introduce glaucoma surgery in these private residence setup, and that was just at the moment MICS arrived the market, and yes, we should. I started early on the beginning with up external. One of the paradigms of up external was these tension suture. And he told me, yeah, of course, you're right, but we've made a subgroup analysis and we have seen dilation alone works well. And it's less traumatic, it doesn't take as long as an up external approach. And yes, around 6-7 years I started with these old iTrack device. But up internal combined with cataract surgery, that is my routinous procedure now for patients with cataract and a coexisting glaucoma. A lot of patients telling me after surgery, I'm so happy. My vision is good, but I'm so happy too that I don't have to take any drops. That means quality of life. Younger patients with phakic eyes, the up internal approach is safe. The risk of inducing a cataract is low in my experience. Yes, you can do it as well as a standalone procedure. As a glaucoma surgeon, you should ever have a plan B. More intact tissue offers you a wide range of different additional approaches. What we do within the up internal approach is only opening the trabecular meshwork on one side, less than 1 clock hour, and then we only stretch Schlemm's canal, stretching trabecular meshwork. There is no additional damage. In the vast majority of our glaucoma patients, the outflow resistance is located in the trabecular meshwork, within Schlemm's canal, and in the distal pathway. So why only addressing with a small stent the trabecular meshwork? Does it make sense to open up Schlemm's canal? Yes, it makes sense. Does it make sense to address collector channels? Yes, we know from different studies that there are hinge-like valves which are oftenly closed. There are oftenly herniations of the distal outflow, collector channels. And that's why it makes absolutely sense, if we want to improve natural outflow, to address all of these three components. With the new iTrack, not, but with the old one, yes, I added it to other mixed procedures. With the new iTrack Advanced, it makes it so easy to get into Schlemm's canal with a limited damage of tissue. The next is you can add to the Canaloplasty alone procedure. You can open up trabecular meshwork, make it to a GAT one. It would be challenging after cutting procedures. There is a leak of trabecular meshwork, but if there is a previous eye stent, you can do canaloplasty. In most cases, the stent will stay in, so it could be challenging, for example, with an hydrus, but it is possible. No, that is one of the safest procedures in my hands. With the iTrack Advanced system, we can inject a lot of viscoelastic, which opens up but tamponated at the same time the collector channel. So the risk of bleeding is very, very low compared to other angle-based surgeries. So we have seen that the IOP lowering effect is on the upper level of canal-based procedure. It lies between 25 to 30%. We can open it, we can add a goniotomy, which delivers oftenly a lowering effect of more than 40%. But vast majority of my patients are fine or more or less controlled with 2, max 3 medication. And in this patient population, combined with cataract surgery, usually more than 80% are off medication after surgery for a long time. If you compare it to the approach with the traditional iTrack, it uses the same catheter, which is very good. It's atraumatic. It follows the Schlemm's canal, but the application was much more difficult. So now we have a single-use handpiece with a slider, which makes it so easy for us to open trabecular meshwork, push the catheter forward really fast, and to hold it in position. So it's a complete different surgery compared to the old approach with the traditional iTrack. First of all, we use this illuminated catheter, which gives me the best control to see where I've opened. Is it within the canal? Should I change something? The second thing is I can titrate the amount of viscoelastic and add much more than in any other canal-based procedure.